Hello everyone. Today we are talking about hyperkalemia, high level of the potassium in the blood, and hypokalemia, low level of the potassium in the blood. We will discuss the different effects in the body due to the hypokalemia and the hyperkalemia. So let's get started. First of all, we will see the distributions of the potassiums in the body. Potassium concentration inside the cell is high. It means that it is important intracellular cation, while the concentrations of the potassium outside the cell will be low. If you see, the intracellular potassium will be 98% and the extracellular potassium is just 2%. It shows that the extracellular potassium is low. Okay, but why these concentrations maintains inside your body? What factors or what important component that maintains the concentration of the potassium inside the cell high? So that is the sodium potassium pump. Sodium potassium pump. 3 sodium will move outside and at the same time 2 potassium will move inside the cell. So that is the important sodium potassium pump that will utilize the ATP and transport the sodium outside and potassium inside the cell. So this is how potassium is maintained high inside the cell. If you see, we measure the concentrations of the potassium in the serum, not in the blood, because in the blood there are a lot of different cells, red blood cell, platelets, which having also potassium inside them, but we just measure the potassium in the serum. So serum potassium level will be 3.5 to 5.0 millimole per liter. So this is the concentration in the serum, not in the blood. So that is the important thing. If in some cases hemolyzed sample, the concentration of the potassium in the serum start increasing, because when the red blood cells hemolyzed, then ultimately the potassium inside the red blood cell start releasing into the serum, and the concentration of the potassium will increase, even though the actual concentration will not be the same. So next we will see the acid base effects on the concentration of the potassium in the acidosis. So you see, the most important thing in acidosis, the H positive hydrogen ion concentration start increasing in your blood. And before discussing the acidosis, you have to consider, or you have to understand, the pH is inversely proportional to the concentration of the H positive ion. When the concentration of the H positive ion starts increasing, the pH start decreasing, and decrease in pH goes towards the acidosis. So 7 is the neutral pH, and if it starts increasing towards the 14, then it will become the alkalosis, and if it starts decreasing below the 7, then it will goes towards the acidosis. So in our case, H positive concentration start increasing, pH start decreasing, and it goes towards the acidosis. And our body will try to compensate the concentrations of the H positive ion. So what will happen? The H positive ion starts moving inside the cell. Similarly, to balance the concentration of the ions inside the cells and in the blood, potassium will start moving in the blood. So ultimately, the potassium level in the blood start increasing, and it goes towards the hyperkalemia. So that is the important thing. In acidosis, our body will compensate the concentration of the H positive ion and start releasing the potassium inside the blood, and it goes towards the hyperkalemia. Similarly, opposite case will be alkalosis. In that case, the H positive concentration start decreasing. Decrease in the H positive concentration, increase in the pH, and increase in the pH goes towards the alkalosis. But in that case, again our body will try to compensate the A concentration of the H positive ion. So H positive ions inside the cell start moving into the blood. Similarly, the potassium that is already present in the blood start moving inside the cell. So ultimately, the concentrations of the potassium inside the blood start decreasing, and decrease in the potassium goes towards the hypokalemia. So in alkalosis, you will see the hyperkalemia. Acidosis, hyperkalemia, and alkalosis, hypokalemia. So that is the important thing regarding the acid-base effects. Next, we will see the what will be the effects on the heart uh, in case of hyperkalemia and hypokalemia. So before discussing the different changes on the ECG, we will discuss the normal ECG. So in the normal ECG, you will see the three most important waves and the three most important segments. In that case, you will see the first is the P wave that will form during the atrial depolarization, and second is the QRS wave, and that is produced during the ventricular depolarization, and the T wave that forms during the ventricular repolarization. And the three most important segments you will see: PR segment, QRS complex, and a third is the ST segment. So these are the major and the important segments on the ECG. When the concentrations of the potassium start increasing in your blood, what changes you will see on the ECG? You will see three most important changes. First is the prolonged PR segment. PR segments start increasing. So this is the one thing or one change that you will see on the ECG. Second is the wide QRS complex. Here is the normal range of the QRS, but in the hyperkalemia you will see the wide QRS complex. And the third thing that is most important, tall T wave. T wave size starts increasing. So that is the third important thing which you have to remember. First is the prolonged PR, second is the wide QRS complex, and third is the tall T wave that you will see during the hyperkalemia. Because in the hyperkalemia, heart muscles depolarization increasing. So in that case, you will see it will disrupt the sodium channels in the myocytes, and in that case, you will see ventricular fibrillation, and it can also go towards the asystole, and that ultimately goes towards the cardiac arrest when they stop beating. So that is the important thing which you have to remember in the hyperkalemia. Next, what will you see in case of hypokalemia? So in that case, you again see the three most important changes. First is the reduce in the size of the T wave. That is the first thing. Second, you will see the formation of the U wave. Here is the formation of the U wave. Normally there will be the no, after the T wave there will be the no wave formation on the ECG, but during the hypokalemia you will see after the T wave you will see formation of another wave, and that is the U wave. Reduce in the size of the T wave, formations of the U wave, and again you will see ST segment. You will see the depression of the ST segment. Here is the ST segment that is straight on the normal ECG, but when you see the depressed ST, in that case it will merge and form a single depression. So that is the ST depression, reduce in the size of the T wave and formations of the U wave in the hypokalemia. So these are the major things that you will see, or major changes that you will see in the hypokalemia, and it actually disrupt the normal ECG, and it goes towards the arrhythmia, cardiac arrhythmia in that case. So this is the normal and the abnormal ECG during the hypo and the hyperkalemia. And similarly, it will also neurons will also be affected by the hyper and hyperkalemia, and in that case you will see the depolarization and repolarization in the neurons, and due to the abnormal hyper and hypokalemia you will see the muscles weakness, because the neurons send signals to your muscles, and the muscles uh, actually your muscles will be controlled by the neurons. When the neurons disturb due to the hypo and hyperkalemia, then in that case you will see the muscles weakness, and sometimes it can go towards the paralysis and cramps also be seen in that case. So neurons will also be affected by the hyper and the hypokalemia. Next we will see the what will be the effect on the kidney. So when we see the normal structure of the nephron, you will see the proximal convoluted tubule, loop of Allen, and the distal convoluted tubule. And in that case, you will see the glomerular. In the glomerulus, you will see the glomerular filtrate present in the Bowman's capsule, and in that case, it will start moving inside the tubes. Okay. So normally, when the this filtrate moves towards a distal convoluted tubule, then what will happen? Under the influence of the aldosterone, sodium from the lumen of the tube start moving inside the tubular cells, and at the same time potassium will start moving in the lumen of the tubule. Okay, that is the opposite effect. Sodium will move into the tubular cells, and the potassium from the in the tubular cell will start moving into the lumen. Okay, and another thing which you see, H positive will also be excreted by the tubular cells into the lumen. So that is a normal process happening in the distal convoluted tubule under the influence of the aldosterone. Okay, but what will happen when you see the high level of aldosterone and low level of aldosterone? Under the high level of aldosterone, potassium excretion start increasing, and potassium will start excreting in the urine. Then ultimately the potassium level inside the blood start decreasing, and it goes towards the hypokalemia. When you see the low level of aldosterone, then potassium excretion start decreasing, and the potassium level in the blood start increasing, and it goes towards the hyperkalemia. So that is the important thing under the influence of the aldosterone. But in the CKD patient, chronic kidney disease patient, you will see the reduce in the glomerular filtration rate, and you can also see the disruption in the tubular cells. So in that case, the excretion of the potassium start decreasing, and ultimately you will see the potassium level inside blood start increasing, and it goes towards the hyperkalemia in the CKD patients. So next we will see the hormonal regulation, how different hormones regulate the concentrations of the potassium inside your blood. So as we have discussed, the most important, aldosterone. So in aldosterone basically uh, promote the excretion of the H positive ion and the potassium ion, and similarly it promote the retention of the sodium ion. So when the concentration of the aldosterone high, and high concentration will be seen in the Conn syndrome, and in that case high aldosterone mean it promote the excretion of the potassium in the urine. When the loss of potassium in the urine start increasing, then the potassium concentration inside the blood start decreasing, and it goes towards the hypokalemia. Similarly, it promotes the excretion of the H positive ion. H positive ion start excreting in the urine, then ultimately the concentration of the H positive ion in the blood decrease. When the H positive ion concentration start decreasing, then pH start increasing, and increase in the pH goes towards the alkalosis. So that is the important thing regarding the high level of aldosterone. So opposite will be in case of low level of aldosterone. Low level aldosterone means potassium will not be easily excreted in the urine, and the level of the potassium start increasing inside your blood, and it goes towards the hyperkalemia. Similarly, it also not promote the excretion of the H positive ion. So in that case, what will you see? The in the blood you will see the acidosis, because pH start decreasing due to the increase in the concentration of the H positive ion. And the most important hormone that regulate the potassium level inside your body, and that is insulin. Insulin actually promotes the sodium potassium pump. So in the sodium potassium pump, you will see the 3 sodium will start moving outside the cell, and the 2 potassium start moving into the cells due to the sodium potassium pump. In the diabetic patient, you will see the let's suppose if I say there is a deficiency in the hormone, that is insulin, in the diabetic patient, so this pump will not work properly. Then what will happen? the potassium inside the blood start increasing, because this potassium normally will not enter into the cell, and the extracellular potassium start increasing. So in that case you will see the hyperkalemia. So that is the important thing. But in the diabetic patients you will see the acidosis. Blood pH start decreasing and it goes towards the acidosis, and we call it diabetic ketoacidosis. So in that case you will see, as we have discussed, sodium moves outside the cell and the potassium will move inside the cell. That is the normal. In diabetic patient, insulin is not properly produced. So in that case what will happen? So potassium concentration inside the blood start increasing. So that is the most important thing. First is the influence of the sodium potassium pump that causes an increase in the concentration of the H positive ion. And second thing that actually promote the level of the potassium is the acidosis. As we have discussed, in the acidic condition, the H positive concentration inside your blood start increasing. So two most important factors that increase the concentrations of the potassium in the diabetic patient. First is the sodium potassium pump that is not work properly due to the deficiency of the insulin, and second is the acidic condition inside the blood of the diabetic patient. So these two important factors that promote the level of the potassium inside their blood. So what will happen? So we actually have to give the insulin that will promote the sodium potassium pump, and that will normalize the potassium concentration inside their blood. So if the patient take the insulin, so insulin actually promotes the proper working of the sodium potassium pump, and when the sodium potassium pump works properly, then ultimately the potassium from the blood start moving inside the cell, and ultimately the level of the potassium starts normalizing in their blood. So that is the important thing in the diabetic ketoacidosis. So this is the important thing, because in the diabetic ketoacidosis, potassium level is not high in their body. It will high just because of the release of the potassium from their cells into the blood. That will actually looks high in the electrolytes test, but it is not actually high. That is the important thing in the diabetic ketoacidosis. So if we summarize all things that we have learned today, first is the hyperkalemia. What causes of the hyperkalemia? Renal failure, because in renal failure, tubule will be disturbed and the potassium excretion will decrease, and decrease in the potassium excretion increase the potassium level inside your blood. Acidosis will promote the potassium level, and tissue breakdown, because tissues release obviously will release this lot of potassium in the blood. And drugs like potassium sparing diuretics that promotes the level of the potassium inside your blood. And addison disease when you see the low aldosterone level inside your blood. Next is the what condition you will see in loss of potassium or hypokalemia: vomiting, diarrhea, magnesium deficiency, because magnesium maintains the sodium potassium pump. Due to the uh, magnesium deficiency, so potassium excretion start increasing, and blood potassium will start decreasing inside the body of the patient. And the Cohen syndromes, that is the important thing, when the aldosterone level starts increasing, so it promotes the excretion of the potassium inside the urine and decrease the serum or the blood potassium level. So this is all about the hyperkalemia and hypokalemia. If you still have any question, you may ask in the comment section. Thank you so much.